مساء الخير. مساء الخير.
اتفضل يا دكتور طارق.
مساء الخير، وحشتونا جدا جدا جدا، واهلا بكم في افتتاح الاسبوع الثاني من مؤتمر وحدة الرعاية المركزة جامعة عين شمس. الاسبوع اللي فات كان لنا اول جلستين، نرجو ان احنا نكون على قد مسؤولية ونكون قدمنا معلومات جيدة في الاسبوع السابق، سواء في الخميس او في يوم الجمعة. الاسبوع ده ان شاء الله هنحاول نقدم مادة دسمة جدا هيشاركنا فيها مجموعة من احسن دكاترة الاطفال في جامعة عين شمس. ارجو ان تكون المادة اللي احنا هنقدمها تكون ممتعة ومفيدة كما نتمنى دائما. المودريتور بتاعت الجلسة النهاردة 2 من eminent professors على مستوى مصر كلها، مش مستوى جامعة كلية الأطفال. الأستاذ الدكتور أحمد البيومي، أستاذ طب الأطفال ونائب جامعة المنصورة، صديقي الحبيب، وطبعا علم من أعلام الرعاية المركزة. وطبعا وجوده معنا شرف كبير جدا جدا جدا. هو غزير في العلم والأخلاق والثقافة العامة والخاصة طبعا في طب الأطفال. دكتور أحمد أهلا بيك ومنورنا ومشرفنا دائما. ويشاركه في المودريتور صديقتي العزيزة وزميلتي وزميل دفعتي الأستاذ الدكتور إلهام حسني، أستاذ طب الأطفال وأستاذ المناعة، ومش هقول عليها غير إنها إلهام حسني، يعني كفاية إن قال إلهام حسني عشان نعرف إحنا بنتكلم عن مين. أخلاق، علم، ثقافة، كل الحاجات الجميلة موجودة بالإلهام أنا أعرفها من ساعة ما بدأنا الحياة العلمية في الكلية ولحد يومنا هذا تجمعنا كل يعني كل حاجة جميلة. عمري ما شفت من دكتور إلهام غير كل خير، عشقها الغير طبيعي للعينين بتوعها والمرضاها والعلم بتقدمه. دكتور إلهام ربنا يخليك ويحفظك دايما لينا والوحدة المناعة اللي انت أنشأتيها بعد الأستاذ الدكتور العظيم أستاذنا العظيم، أنا اسود واحد ذكرته ضاعت،
فطبعا
دكتور يحيى جمال ربنا يخليه يديله الصحة. فطبعا مش عارف أقول لحضرتك إيه، دكتور يحيى أنشأ الوحدة، وأنت ودكتورة زينب عوض ودكتورة شيرين شلتوا المهمة من بعده. أعتقد إن أنتوا فعلا كنت خير سلف خير سلف، ودائما وأبدا بيكون عند حسن المسؤولية، وإحنا بيسعدنا ويشرفنا جدا 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 وجودك معنا. دكتور إلهام أهلا بيكي، دكتور أحمد أهلا بكم وتشرفونا دائما.
Thank you very much, Dr. Tariq, for this very generous presentation. الحقيقة أنا سعيدة جدا بوجودي النهاردة معاكم. أنا بعتبر وحدة الرعاية المركزة دي يعني من أهم وحدات مستشفى الأطفال جامعة عين شمس. ما نقدرش نعيش من غيركم وما نقدرش نمشي شغلنا من غيركم. فأنا سعيدة جدا بوجودي معاكم، وأنا كل سنة منتظمة في المؤتمر ده من أيام أخي دكتور محمود طارق، وليا الشرف ان اكون معاكم فيه. برضو بيشرفني جدا النهارده ان انا اشارك مع الاستاذ دكتور محمد عطيه البيومي، استاذ طب الاطفال والرعايه المركزه في المنصوره، وانا يعني سعيده بمعرفته وباننا هنتعاون مع بعض النهارده. الحقيقه السيشن مليانه بتوكس غنيه وقويه جدا. احب ابتدي حاليا بكابل هيقدموا أول برزنتيشن. سمر أحمد حسن مدرس مساعد طب الأطفال هتقدم لنا كيس برزنتيشن عن مياه سايلنت انفيدر، وهتعلق عليها حبيبتنا الأستاذ دكتورة إيمان رجب، هنقدمها بعدين. بس يا ريت يا سمر نبتدي دلوقتي and stick to the time. أنا بطلب من كل السبيكرز إن هم يتكرموا بالالتزام بالوقت المحدد. شكرا.
دكتور إلهام، أنا آسف جدا، أنا دكتور محمد عطية، أنا آسف جدا، بس أنا الضغط عندي عالي قوي فمش قادر أركز. أنا آسف لأقصى قدر ممكن، أنت عارف محبتك عندي، بس أنا فعلا ضغطي دلوقتي 180 على 120 فأنا تعبان. أنا آسف.
سلام عليك يا
أقصى
دكتور
قدر
ألف سلامة ليك يا طارق.
ألف
فأنا
سلام على حضرتك،
أوني
ويعني
أنا
اطمئن عليك يا
جدا،
رب تكون بكل خير.
مش قادر أركز قوي دلوقتي، معلش اعذرني يا دكتور محمد، أنا
لا حبيبي،
معتذر.
ألف سلامة على حضرتك، وبيسعدني دعوتك ودعوة الدكتورة حنان، وبيشرفني وجودي مع يعني العلم الكبير الأستاذة الدكتورة إلهام حسني. شرف ليا يا هانم، ومش عايزين ندور على وقت الجلسة العلمية، فحضرتك اتفضلي، ولو دكتور مروة جاي.
Professor,
دكتور سمر عفوا.
colleagues, we'll start our first session with case presentation. Nagwain Muhammad, 15 years old, female patient, fifth order of birth of non-consanguineous parents. He was born and lived in Asyut. She presented to the ER with disturbed level of consciousness of acute onset, progressive course of 3 days duration. The patient presented with a complaint of persistent headache of 1 month duration of acute onset, progressive course all through the day, not associated with glaring of vision or vomiting. She sought medical advice and brain imaging was done, but with no documentation. Also, she didn't receive any medications. Regarding the past history, though there was no previous operation, no blood transfusion or hospital admission. She was completely normal motor and mental milestones. She received all her vaccination with no complication. There was no relevant family history. On examination, she was ill, toxic, tachypnic with signs of proptosis on the left side of the eye. She was unconscious. Vital data was completely normal. Local examination was completely free except neurologically, as Glasgow Coma scale was 8/15. She was hypotonic on the right side, affecting both upper and lower limbs, with deep exaggerated tendon reflexes on the right side, with presence of pathological reflexes, with the power could not be elicited. The patient then was intubated as Glasgow Coma scale became 6/15. So our initial differential diagnosis was, is it CNS infection, meningitis or encephalitis? Is there a space occupying lesion? Is there head trauma or hemorrhage? So investigations was done laboratory and radiologically. Laboratory investigations as regarding the CBC was normal except with low normal lymphocytic count. CRB was high, more than 250. Kidney function was high, but with time it started to develop elevated bun and creatinine. ESR was high, 120 millimole per hour. So we did viral marker, hepatitis B and C, and also HIV, which were all are negative. Chest examination was done on admission. So as the patient was disturbed level of consciousness, we did a CT brain, which show complete opacification of both ethmoid and sphenoidal sinuses by hyperdense material with bone destruction of the ethmoid and sphenoidal sinus. So we proceed for MRI brain, which also show invasive fungal infection compressing the optic nerve, and we could see also a left eye proptosis. Also, the maxillary sinus was destructed with also a fungal infection. The patient was more disturbed, so another CT brain was done, which show acute, subacute non-hemorrhagic infarction affecting the frontal and parietal areas. Carotid duplex was done with showing more than 15% stenosis in the right internal carotid artery, middle cerebral artery, with also manifestation of increased intracranial hemorrhage. So we found that there was low normal lymphocytic count, high ESR, also invasive fungal sinusitis affecting the brain. So immunological consultation was done. So they recommended to do immunoglobulins. Immunoglobulin A was normal. Immunoglobulin G was slightly high normal. CD markers was done with showing low CD3, CD4, and CD19. So we have low normal lymphocytic count, low CD3, CD4, CD19, high normal immunoglobulin G, mostly non-functioning B cells, with also disseminated fungal infection in the brain. So another differential diagnosis was added, which goes with late onset combined immune deficiency. So the plan was to do a check for memory B and cells with a specific antibody response, give IVIG on 1 gram, keep on double antibiotics. Also, we considered to do a biopsy, which showed necrotizing granulomatous sinusitis, possibly of fungal infection. The patient was admitted on antibiotics and antifungal. Unfortunately, the patient developed septic shock. We couldn't continue the investigation and she passed away. So our final diagnosis was a case of query late onset combined immune deficiency with severe disseminated fungal infection complicated with septic shock. And thank you.
Thank you very much, Summer, for sticking to the time and your clear presentation. We were asked by one of our guests, who is a foreigner, to speak in English so that he can follow the session. And now I am very to present Professor Iman Ragab. Professor Iman Ragab is an eminent professor in Ain Shams University in hematology and oncology, pediatric hematology and oncology. We are very proud to have Iman Ragab in the Ain Shams team. She's very dedicated to her patients. She's one of the most honest physicians I've ever seen in my life. I'm very proud to present Iman Ragab. She will give us a presentation about antifungal disease. Thank you very much. Go ahead, Iman.
Okay. Bismillah ar-Rahman ar-Rahim. I would like to thank you, Professor Ilham. You know very well that you are a role model for all of us for the sincerity, and we are very proud for me to present while you are chairing the session, and I'm indebted to the whole pediatric ICU team. They know very well that I love them very much. They are on our back in every single patient who gets critical. And I'll start my presentation by taking the, I don't know, the slides are not, yes. Are the fungi that we are eating the same fungi that we get infected with? There is more than 100,000 species of fungi. The microscopic fungi that causes illness inside the human being are either molds or yeast. The fungal infection either are superficial, that usually we encounter like tinea capitis, like dermatophytosis, but I'm concerned today with the deep mycosis. Where do fungi live? They live everywhere. And especially I want to highlight that whenever we are in the hospital environment and we have construction, we have to make the very strong curtains and shields around the construction area, because after the construction, usually the patients get significant fungal infection. They live on the top of cockroaches. They live in the black pepper. So this is the site of concern of probable presence of fungi. The fungi are divided into yeast, like the prototype is Candida species, and Cryptococcus neoformans are less common, and molds. Molds are divided into Aspergillus, Penicillium, Fusarium, Pseudosporium, and Mucor. Why are we talking about invasive fungal infection? Because even in the 2000 years, and even in Japan, in hematopoietic stem cell transplant, mortality rate due to invasive fungal infection had topped up to 50% in some settings. Our talk will be about antifungal decision to diagnose and decision to treat. So whenever we take a decision to diagnose, we have like plotting a certainty chart. When we're not very much certain of diagnosis, it's called possible. When we're more confident, it's probable, and then it's proven. Proven fungal infection is not an easy job to attain, and usually we do not attain a proven fungal infection. And those definitions are based on these definition published in 2008 on the invasive fungal infection by the European Research and Treatment of Cancer Group and the Mycosis Study Group. They plot definition based on some host factors, some clinical criteria, and some mycological criteria. When host factors are present with the clinical suggestive clinical criteria and mycology in the form of blood culture and tissue, it's called proven infection. When the mycology are not certain and they are indirect, it's called probable. When there is no mycological criteria, it is called possible. And when the host only the host factor with the mycology and asymptomatic patients, it's not in these criteria classified. What about the host factor? The host factor, for sure, it means immunocompromised host, either by prolonged neutropenia more than 10 days and less than 0.5 per microliter, or the presence of immunodeficiency, especially affecting the innate immunity and the T cells, or by medication attacking the immune system, like prolonged corticosteroid use, like allogeneic stem cell transplant and T cell immunosuppressant agent. Going to the clinical criteria, if you are found in the trachea ulcers or black scar, in the radiology, this is very important to in the 4 signs suggestive of fungal infection, either nodular lesion or a nodular lesion with a halo sign around the nodular lesion, or going into a air crescent sign, which is progress of the lesion and then cavitation. Those are the signs in the radiology suggestive of invasive fungal infection. And continue to the clinical criteria. If I find a sinusitis with a mass are eroding the bone around it, usually it's an invasive fungal infection, although there is other differential diagnosis, but the invasion for itself makes us think of fungal infection. In the presence of CNS lesions in a suggestive clinical setting, this is very suggestive. As regards the mycological criteria, we have either direct tests to find a bronchoalveolar lavage or sinus aspirate with presence of fungal element, this aspirate or bronchoalveolar lavage, or the recovery of a culture of a mold like Fusarium or Aspergillus, or we have indirect test, and in few seconds I will mention the galactomannan testing. The indirect test is the cell wall constituent of the fungi. To have a proven fungal infection, for sure fungal infection, I have to document either blood culture with fungal infection, either a mold or yeast, or to have a histopathological confirmation of inflammatory reaction, and inside the inflammatory reaction of the mold, the part of the fungal element which was not encountered in the case, unfortunately, or to have a CSF with presence of cryptococcal antigen inside the CSF, and the cryptococcal is very common in the HIV population with very low CD4 count. This is for the first decision to diagnose. The second decision is decision to treat. We have several groups of antifungal agents, the azole group, the itraconazole, and I want to mention that the itraconazole formulation in Egypt, their capsular form do not have the solution form, or we prepare it, and the solution form has a higher bioavailability. We have the voriconazole, posaconazole, and the very famous fluconazole, the echinocandin, caspofungin, and micafungin, and the polyene group, like the amphotericin and its formulations. The polyene group, which is the amphotericin, cause like a tubular or disrupt the membrane, and they are not specific for the wall of the fungi. They do the same for the renal tubular system, and that's why the nephrotoxicity is very common in this the polyene group. The azole group, they inhabit the ergosterol synthesis, so they are less toxic as regards the membrane toxicity, and the echinocandin, they inhabit the beta-glucan, so the toxicity profile is less. And there is long life timeline of the antifungal agent, and whenever resistance show up, another antifungal agent show up, and we have recently an anidilofungin present in Egypt. the decision to treat, we should consider sensitivity, toxicity, and for sure the cost, because they are expensive medications, and the toxicity profile for example, for the amphotericin group, in amphotericin B lipid complex or liposomal form, they have still nephrotoxic effect. So this is one of the points that we should consider during the decision taking. During decision taking, we have two policies, either proactive or reactive. Whenever I have a very high prevalence of fungal infection like hematopoietic stem cell transplant, I advocate for prophylactic. Prophylactic is a proactive, not a reactive. And whenever the fungal infection is less, I would do a symptom-based or diagnostic-driven approach to treat. This is the different approach. And whenever I take a decision of antifungal agent, I have to put on consideration the published data about the sensitivity. Yet we have to do an institutional-based sensitivity pattern, and this is very important. So I want to mention that for our institution in Ain Shams University, we have lots of Candida glabrata, which shows less sensitivity to fluconazole, for example. And we have lots of Aspergillus fumigatus, and the sensitivity still for fluconazole species is not very much high. The mucor, because I want to mention the mucor later on, is not sensitive to most of the antifungal agents, so it's sensitive to amphotericin B, which is different with its different formulation. During taking the decision for antifungal strategies, I may do prophylactic, empiric, preemptive, or very specific treatment. This depends on the likelihood of the infection at the proper. So whenever I have prophylactic, I do not, before development of symptom, if I have symptom and clinical criteria, I would do empiric treatment. If I have mycological criteria, I would do preemptive treatment. If I have tissue diagnosis, I would do very specific antifungal management. I will just mention a few points about each fungal infection. In the Aspergillus fumigatus is the common organism you encounter in our daily practice. In the invasive fungal infection, basically we have a nodular lesion with a halo sign and then air crescent sign. This is very common in the Aspergillus infection. What about the galactomannan test? The galactomannan is, for now, the commonest test used to diagnose fungal infection. There is no cutoff level in the pediatric age group. 0.5 is the cutoff level in the adult population. In the pediatric, we depend on a rising fluorescent of 0.5, 0.3 about the rising titer. If it's 0.2, it rose to 0.4, so it's considered infection. And I want to mention that some of the antibiotics you are using, like tazobactam, for example, give false positive galactomannan testing in the during the treatment, and the fusarium species, which we started to see during our practice, is give false positive result with the galactomannan. The beta glucan are less commonly used. The PCR, up till now, they're not validated for diagnosis of Aspergillus infection. Recommendation of Aspergillus for first line voriconazole. Yet I want to mention that with the azole group, we have to do therapeutic drug monitoring if they fail treatment, because many drug interaction with the azole group. So I cannot declare failure of the azole group except if I do a therapeutic drug monitoring or TDM. As regards the candida, the invasive candidiasis usually is not commonly caused by albicans only, but also the non-albican species. I want to highlight the presence of Candida glabrata and Candida cruzi. And whenever I look at the fungal of the culture, please double check the MIC, because if it's high MIC, I have to choose the antifungal agent with low MIC. And during the invasive fungal infection, the number one choice is echinocandins, although we are usually using fluconazole, yet because of the emergence of the non-albican species, so there is decline in the use of fluconazole as first line in invasive candidiasis. So again, caspofungin and micafungin, they are used prior to fluconazole in the invasive candidiasis nowadays because of the emergence of the non-albican species. As regards cryptococcal neoformans, we usually cause CNS infection. It's been thought with the treatment of the complication of HIV, it's detected by CSF analysis of cryptococcal antigen. As regards the mucormycosis, which is, I guess, the child you presented, Dr. Summer, probably it's mucor. It's a rapid onset of tissue necrosis. These are the clinical picture: fungal eroding sinusitis causing proptosis, usually a black scar because they do pigmentary changes, and it erodes the sinuses and goes to either endogenously to occlude the nasal cavity or exogenously to appear on the skin. And the mucormycosis may cause pulmonary infection with angioinvasion. And we lost one of the patients because mom refused to do surgery because the angioinvasion may cause aggressive, severe hemoptysis. The cutaneous mucormycosis gives a black scar, and this is the clue sometimes. In gastrointestinal, we do not see it commonly, and disseminated, we do not see it commonly. The mucormycosis diagnosis, we do not have a serological test. They should have a biopsy with mucor inside the biopsy of inflammatory reaction. This is very important to highlight that whenever I suspect or I prove a mucormycosis, the conventional treatment is not valid. So we have to use very high dose of amphotericin B, reaching to 10, even sometimes milligram per kg of liposomal amphotericin B. The minimal dose is 5 milligram per kg. It's not the regular 1 to 3 dose we're using in the invasive aspergillosis. The second line is posaconazole, but it is FDA approved more at the age of more than 13 years. It's not FDA approved less than 13 years. Let's not forget that the pneumocystis pneumonia or pneumocystis jirovecii is one of the antifungal fungi. Now it's classified as fungi. And whenever I have immunocompromised host with interstitial pneumonitis, I have to think of pneumocystis jirovecii as well. And I cannot end the talk without mentioning that whenever I treat COVID and the patient is not responding, please think again that there is super added fungal infection. And this is one of the cases which was recently published, and they found that the patient did not respond well to the treatment. And when they added voriconazole to the conventional treatment, the patient marvelously responded and was extubated. And I'm very indebted to the group. I'm working with the hematology oncology group. I hope that we have like antifungal strategy in our institution, because many of the departments are using antifungal agents, and it's not like an antifungal stewardship should be done in the hospital. And thank you.
Thank you very much.
Thank you very much, Iman. Thank you for the first team today, Summer and Iman. Summer made a very clear presentation, and Iman gave us very valuable knowledge about fungal infections in pediatrics. So we are happy with it. And now I give the mic to my colleague, Dr. Muhammad Atiyah.
Thank you very much, Professor Ilham, and thank you very much for our two first speakers. Before I proceed, I'd like to confirm to our participants, Walid Hassan, Sahar Hussein, and Tariq Atiyah, that we do see your questions and will be proceeding with answers at the end of the session. Now let me introduce the next two speakers. They will be Dr. Nihad Bakri, Assistant Lecturer of Pediatrics at Ain Shams University, and Professor Marwa Deep, the Professor of Pediatrics at Ain Shams University. We'll start with our first speaker, Dr. Nihad Bakri, and she's going to talk to us about the incognito enemy. Please, Dr. Nihad.
Good evening, dear professors and colleagues. I would like to thank you, dear Professor Muhammad, for your kind introduction. Let's start our journey with this case presentation to discover this incognito enemy. Joseph is a 12 years old boy, non-consanguineous parents, who was born and lives in Minya. Joseph was presented complaining of shortness of breath, sudden onset of progressive course, and of 1 week duration. The condition started before fever of sudden onset and progressive associated with sore throat, arthralgia mainly shoulder and knee joint, and abdominal pain, which was colicky, more on right side, not associated with vomiting or diarrhea. Patient sought medical advice and he was started treatment by antibiotics, intestinal antiseptics, and antibiotics with partial improvement as case of acute tonsillitis. Suffer from fever with loss of appetite, abdominal pain. 4 days before referral, patient developed tachypnea that progressed to dyspnea. His history of present history was irrelevant except for oral antibiotics. He received vaccines according to EPI without remarkable complications with regional vaccines. Regarding his family history, there was no history of similar conditions or chronic illness. In the Mirdash Hospital, pediatric ER, patient was conscious, alert, oriented, ill, udesnic. On examination, generally patient was feverish, 39.5, tachycardic, tachypnic, with oxygen saturation 95. Locally, chest examination showed diminished re-entry on right side with bilateral fine crepitations, systolic murmur and gallop rhythm. His abdomen was lax with tender hepatomegaly, palpable tip of spleen, and finally neurological examination was unremarkable with Glasgow score 15. Initial investigations in ER showed elevated count with lymphopenia, normocytic normochromic anemia, CRB, and ESR. Metabolic profile was unremarkable except for and slightly elevated ALT and ST with elevated LD. Initial chest X-ray in ER showed that right-sided pleural effusion and cardiomegaly and increased bronchosvascular markings, showed moderate precardial effusion without pathological valve lesion and elevated troponin I cardiac enzymes. Patient was admitted to BQ. On admission, patient was in cardiogenic shock on milrinone, noradrenaline, and Lasix infusion with initial IV antibiotics were Fortum, Venco, and Amethane, and follow-up echo was done, showed increased amount of effusion with fibrin threads. Precardiocentesis was done after patients improved the condition and stabilization, which showed exudative serosanguinous fluids with cell count and type bloody, and cultural sensitivity was showed no gross and with negative Zell-Nelson stain. Joseph condition was improving as regards shock, and inotropes were stopped, but patient still feverish. To summarize positive data, signs showed prolonged high-grade fever, transient reddish rash on extremities, loss of appetite and weight loss. The patient lost 4 kilograms in first week of admission, abdominal pain and tenderness, mild hepatosplenomegaly, and axillary lymph nodes, carditis, leukocytosis with lymphopenia, elevated CRB and ESR, normocytic normochromic anemia, and precardial effusion with right-sided pleural effusion. First differential diagnosis: patient persistent with fever, infection, viral, COVID, with Epstein-Barr virus, bacteria like TB, typhoid, brucellosis, inflammatory diseases like Kawasaki, systemic onset juvenile idiopathic arthritis, inflammatory bowel diseases, malignancy, leukemia, lymphoma, causing secondary HLH. As regards infection, no history of diarrhea or vomiting, just fever and abdominal pain. No history of direct contact with animals or drinking unpasteurized milk. Labs COVID-19 was excluded by double negative swab. Gene expert from precardial effusion was negative for TB. HIV, Epstein-Barr virus, cytomegalovirus PCR was negative. Blood, urine, and sputum cultures showed no growth. Only Vidal test showed elevated Salmonella typhi O and H titer. Malignancy also was excluded by flow cytometry from precardial effusion and bone marrow examination, which showed no malignant infiltration. Here, Patient started to be managed as a typhoid fever with a typical presentation. So antibiotics were shifted to IV ceftriaxone and ciprofloxacin, also citrine was added. Fever frequency was decreased to 38.5, 2 to 3 times per day. Other differential diagnosis is still in mind. So pelvic abdominal ultrasound with band CT were done, showed bilateral pleural effusion, posterior consolidation collapse, moderate precardial effusion, and abdominal CT showed thickened edematous wall with submucosal reactional lymph nodes at the region of ilium, cecum, and ascending colon. Echo showed mild precardial effusion with improvement of cardiac contractility. Other investigations like elevated serum ferritin, D-dimer, 25, we consumed fibrinogen, bone marrow showed leukoid reaction, and mild increase in macrophage. Most of them show hemophagocytosis. To sum up, fever, splenomegaly, high ferritin, elevated CD25, wheel bone marrow examination, patient and developed secondary HLH. So other investigations was done like immunological markers, which showed no abnormality, and the other investigations like fecal calprotectin, which was 20 microgram per kilogram and also normal. Patients was still feverish. And in focusing on other lab investigation during admission, lymphoresistant lymphopenia, anemia, and received RBCs once, elevated CRP and ESR, procalcitonin, persistent hypoalbuminemia with persistent Vidal test with high titer for Salmonella typhi O and H. Patient was still feverish as a treatment for resistant case of typhoid. At this point, we have to revise our differential diagnosis together with immunology and the gastroenterology team after excluding viral HIV, cytomegalovirus, inflammatory diseases like Kawasaki rheumatic fever with malignancy like leukemia and lymphoma, spotlight on typhoid, TB, systemic onset juvenile idiopathic arthritis, and inflammatory bowel disease. We narrowed the investigation differential diagnosis to false test, TB, and inflammatory bowel disease, the first two focused, and revise our diagnosis regarding TB. We do quantiferon and planning for gastroenterology, gastrointestinal endoscope. The surprise was quantiferon was positive. Patient started anti-tuberculous treatment. 1 week later, no fever, improvement of appetite. Patient discharged home after treatment and follow-up as a case of TB enteritis. I want to thank all my dear professors and colleagues, residents. I really appreciate your continuous support. I would like to say family are not related to blood, but best friends and sincere professors too. Thank you.
Thank you very much, Dr. Nihad. That was very nice and clear presentation. Before we proceed to our next speaker, may I ask all our participants to put their questions in the section for question and answers so that we can present them to the speakers at the end of the session. Now we proceed with Professor Marwa Elbib, Professor of Pediatrics, Ain Shams University, who will be talking to us about the Chamber of Secrets. Please, Professor.
Thank you. Thank you very much, Dr. Mohammed, for the very kind presentation. Thanks to all the pediatric ICU team, and thanks to my friend, Dr. Nihad, for this very interesting presentation for this case. My name is Marwa Elbib. I'm Professor of Pediatrics at Ain Shams University. So what's the Chamber of Secrets? The Chamber of Secrets is the GIT. And why is the GIT Chamber of Secrets? Because almost all of GIT symptoms are diverse, vague, non-specific. they overlap and coexist with many other systems. And a simple example is vomiting, for instance. It could accompany a simple case of gastroenteritis, and it could be a presentation of a more serious CNS condition. And that's the case with almost all GIT symptoms. So what's the solution to this? The answer to this is to stay focused. We need always to stay focused. We need to try and spot the elephant in the room. And the elephant in the room, in my opinion, is the very strong symptom that lead you to suspect GIT involvement in the disease. And actually, in this case, there were many elephants in the room. So if I would summarize this case, as Nihat said, this patient, before presentation to the ER with this very severe condition of cardiogenic shock, he presented with fever, abdominal pain, arthralgia, and weight loss 2 months before presentation. And this trio is very famous in GIT diseases: fever, abdominal pain, and weight loss. This is a very famous trio. It was your first elephant in the room from the presentation of the patient. I'll take it from here. Nihat did a very good job taking it from the fever, and I'll take it from the chronic abdominal pain view. Chronic abdominal pain, by definition, is any long-lasting or intermittent pain that interferes with the patient's daily activity. And again, because it's one of the GIT symptoms, it's vague, it's non-specific, it's diverse, and it overlaps and coexists with many other system presentations. GIT could be the cause. We have multiple non-GIT causes, and we have functional abdominal pain disorders in which we could not spot an anatomic or structural or biochemical abnormality. If I give you a quick review on the GIT organic causes, if the pain is mainly upper, so it's supraumbilical, we're thinking of acid peptic disorders, infections as giardiasis or maybe typhoid, hepatobiliary stones or hepatitis, or even chronic pancreatitis. If the pain is infraumbilical, so we're thinking more of IBD, inflammatory bowel diseases, infections, again, as TB or Yersinia, or surgical cause. If the pain is diffuse and the patient cannot localize, so again, infections could be the cause, but we could more think of other malabsorption disorders or even allergic disorders. If we want to think outside of the GIT, it could be because of renal pathologies. If she's a female, we have multiple gynecological causes, toxicity or metabolic disorders as the porphyria, or autoimmune disorders. On top, of course, are the periodic fevers. This is the functional abdominal pain disorders. There are a group of disorders in which we could not spot an organic pathology. It's out of our scope today, but the main difference between organic and functional disorders is the red flags. Red flags is always there when you want to suspect organic disorders. A quick summary of the red flags: family history of GIT diseases or of chronic infections, constitutional symptoms as weight loss is on top, of course, and fever, persistent or localized abdominal pain, upper GIT symptoms as the vomiting, bowel changes, diarrhea or constipation, any GIT blood loss, upper or lower, presence of organomegaly or extraintestinal manifestations, especially the skin manifestations. And going back to this patient, to our patient had multiple red flags from the history. Filtering growth is one important red flag. Fever, pain was localized to the right side of his abdomen, organomegaly, he had hepatosplenomegaly, and skin manifestations. I could not categorize it in tuberculous patients and not on IBD patients, but again, he had skin manifestations as an extraintestinal sign. So how to proceed? We have basic investigation checklists, which we call limited investigations. These are the baseline bloods, CBC, CRP, ESR, electrolytes, liver, renal functions, urine and stool. So this is baseline limited investigations. And then we have more targeted investigations in which we're looking for a serious involvement of the GI. Occult blood and stool, fecal calprotectin, fecal elastase and pancreatic enzyme for pancreatic pathology, celiac serology, because celiac disease have a very wide array of presentations, not only the typical malabsorption picture. And then we have a list of other imaging techniques, barium, CT, MRI or MREs, and ultrasound even. And finally, we can look inside the GI through endoscopy and biopsy. In our patients, he had derangement in his CBC, CRP, and ESR, which could not point out to a specific pathology. And he also had a peculiar picture in his ultrasound and CT, and this was the second elephant in the room. I'm not sure if this shows or not. This was the second elephant in the room. The second elephant in the room was what was shown in his CT picture, the ileocecal thickening. Ileocecal thickening is never an easy sign to see in any radiology for a patient with fever, abdominal pain, and weight loss. It's very serious and it's very challenging as well. Why? Because the ileocecal area, it refers to the cecum, the ileum, the ileocecal valve, the appendix. So this is all by itself is the ileocecal area. The ileocecal area in GIT diseases is a perfect crime scene. Why a perfect crime scene? Because it's an area of physiological stasis. It's an area in which there is very rich lymphoid tissue. So whenever there is process of infection, inflammation, neoplasia, the ileocecal area is almost always involved. And that's why it's very challenging. The arrows here point, of course, to the thickening in the ileum, thickening the ileum and proximal cecum. So whenever there's ileocecal thickening in imaging, we have to think of one of three. If either infections, inflammatory pathologies, or neoplasm. These are the three top. There are many other, there's a very long list, but on top are these three: infections, inflammatory, and neoplasm. On top of the infection is abdominal tuberculosis. Although other infection might be there, you're seeing Campylobacter, I see COVID-19 here as well. But the main difference between TB as infection and the other infections is that TB runs a longer course. The other infections usually have an acute presentation. On top of inflammatory pathologies are the inflammatory bowel disease, or mainly the Crohn's, of course, and neoplasm in the younger age is lymphoma, although we can see any kind of tumor at any age. If this is challenging, if characterization, whether it's infection, inflammatory, neoplasm, is challenging, so it's almost more challenging to say, is it abdominal TB or Crohn's disease? This is even more challenging. Because both abdominal TB and Crohn's disease share this very famous trio of fever, right lower quadrant abdominal pain, and weight loss. There are few symptoms, the signs that go more with tuberculous infection. Of course, if there's history of a contact with the tuberculosis, if there is lung involvement, so it's more toward the TB side. If there's a picture of effusion, pleural, pericardial, or ascites, so it's more towards the tuberculous side. And of course, if there are nice sweats. More towards the Crohn's disease is a longer duration of the pathology. So usually patients of Crohn's disease present 4, 5, 6 months after start of the symptoms. Presence of bloody diarrhea is with Crohn's disease. Perianal pathology or extraintestinal manifestation goes with Crohn's disease more. If I'll go back to our patient had lung involvement evident on clinical basis as well as CT, and he had effusion, pericardial and pleural as well. But the duration of disease was not very long, not to think of Crohn's disease. And again, he has skin manifestations not typical of IBD, but I might consider some extraintestinal affection as well. So we're confused. Is it TB or Crohn's disease? So can we do endoscopy? Can endoscopy be the answer? The arrows point out to the abnormalities here. On the left-hand side of the screen, the red arrows show severe inflammation of the ileum, of the terminal ileum and the cecum, with polypoid masses, picture of polyps. And then on the right-hand side, the green arrows show ulcers. The yellow arrow underneath show ulcers. Upwards, I'm not sure about the colors anymore, but it shows severe inflammation. You might think that this is pictures of one patient. Actually, these are 3 different patients. One with TB, one with Crohn's disease, one with the amoebiasis causing cecal ulceration. So what's the conclusion here? The conclusion is that the endoscopic picture, the gross endoscopic picture, does not tell you much, does not differentiate. What about the histopathology? The hallmark of tuberculous infection and of Crohn's disease is chronic granulomatous pathology. The TB, there is caseation, and the arrows here point to caseation, caseation necrosis. But actually, this is textbook. This doesn't happen in real life. In real life, it's very unusual for the histopathologist to say this is caseation necrosis or TB, or this is an epithelioid granuloma of Crohn's disease. This is very unlikely. And it's even more unlikely for a biopsy or a smear and culture to show the acid-fast bacilli of the TB. limitations are huge, not only the experience of the histopathologist, but also the limitation of the staining and the technique by which the biopsy was taken. So again, the biopsy does not tell you much. You need to be very lucky to find this criteria for diagnosis. What about bloods or baseline laboratory investigations in general? The baseline bloods, as we see in this case, the TBC, the CRP, the ESR, does not tell you much. It's all non-specific. It's chronic inflammation or inflammatory process. If I do serology for celiac disease, for Crohn's disease, the ASCA by name, again, it's not conclusive. Most of cases with Crohn's disease do not show positive or high titer of ASCA. What about the PCR, the quantiferone, the adenosine deaminase, whatever, more sophisticated test to test for TB? Before this slide, the idea of the quantiferone is that it investigates or tests the interferon gamma response. And the interferon gamma response is highlighted or takes an upper hand in cases of Crohn's and also in cases of latent TB. So if you find a positive quantiferon, it does not tell you that your patient is 100% TB, but it increases your suspicion that this patient might be TB. And this paper shows that there's always possible false positive quantiferon test in patients with IBD. This is very true. So we're confused, right? Is it TB or Crohn's? The whole world is confused. It's not our case. It is a big confusion. Let me take you back at the global burden of the disease, the global burden of pediatric TB versus the global burden of pediatric IBD. Pediatric TB can reach up to 0.3%, 1 million per year. 0.3% is intestinal, and these data are from India, regarded as the international hub for tuberculosis. The burden of pediatric IBD might reach up to 2.3%, and it's on the rise, of course. Abdominal TB is very unlikely to happen in a host who is not previously immune compromised or having a chronic debilitated illness. It's not usual. It's not usual to see cases with abdominal TB in a previously healthy individual. It could be primary, of course, or secondary tuberculosis. Abdominal, primary ingestion of the unpasteurized milk, and in our case, it was not valid, or secondary spread, hematogenous, or from adjacent lymph nodes in a case of open pulmonary TB. Abdominal TB could affect the lymph node, could affect the peritoneum, could affect the intestine. And if this happens, it will happen always on the right side, which, as I told you, is the perfect crime scene for every GI diseases, or it could happen in solid organs at the liver and the spleen. Intestinal TB could have various presentation, acute, and hopefully our patient was not like this, where it presents with peritonitis, perforation, picture of acute intestinal obstruction, or it could run a more protracted, prolonged course in which it presents with the famous trio of fever, abdominal pain, and weight loss, just as our patient presented. So is it intestinal TB or Crohn's disease? No one knows. No one knows. You should have a very high clinical suspicion, and the differentiating points are very few, just as I highlighted before. Again, the differentiating points based on the labs, the imaging and histopathology, you need to be very lucky to prove it. And the best is the response to the antituberculous therapy. So the best is to monitor your patient and follow up the response to antituberculous therapy. This is a very, very interesting algorithm. It's the agent-specific consensus on Crohn's disease, actually. So I'll start from here, and I added some points just to follow with me. There is always a diagnostic confusion. So if you're confused, if you're not sure if your patient is Crohn's disease or intestinal TB, so it's better to start treatment as intestinal TB. So you start antituberculous therapy, and then you have to follow up the clinical response after 2 to 3 months. You have to follow up the response of your patient. If your patient is not improving, if the clinical response is poor, you have to redo the endoscopy. If at the mucosal level or at the histopathological level, the disease is still active, there is still chronic granulomatous process, there is still cryptitis or inflammation, probably your patient was Crohn's disease who was falsely labeled as a case of intestinal TB. So if the response was bad and the endoscopy and histopathology show quiescence, the disease is not active, so probably your patient is TB, but he's having a complication as a stricture, or he might be a multi-drug resistance TB. So this is one side. The other side of the story, if you start the antituberculous and you follow up the clinical response within 2 to 3 months, and the patient is clinically improving, just like our patient, the fever subsided, the appetite is better, he started gaining weight, so leave him for another 3 months and redo the endoscopy after 6 months of therapy. Usually therapy for intestinal TB takes from 12 to 18 months. So you follow up the clinical response. After 6 months by an endoscopy, you have to do an endoscopy because this clinical improvement should be coupled with a mucosal healing by endoscopy and histopathology. If the patient still having active disease on endoscopy and biopsy, so there is still inflammation, ulceration, and polypoid masses, and the histopathology still shows activity. So again, your patient was a Crohn's patient who was falsely labeled as intestinal TB, and you have to change the whole plan of management. But after clinical improvement and endoscopic improvement, there is healing at the mucosal level. So you were right from the very start, and your instinct was perfectly right, and this was a case of intestinal tuberculosis. So I'm so sorry to tell you this, that this case is not a closed case to me. We still need to follow up. We still need to follow up the response to antituberculous therapy clinically after 3 months, endoscopically and histopathologically after 6 months. So after 6 months doing an endoscope, which unfortunately was not done from the very start, should give you more clear answers. Thank you very much. Thank you.
Thank you very much, Professor Marwa. That was very educational, may I say.
Thank you.
I'd like to thank our last 2 speakers actually for giving us a lesson on how to follow clinical and radiological clues and how to use your clinical decision making, and for very valuable clinical pearls that we've been taught today. I'll hand over to my co-panelist, Professor Ilham, to present our next speaker.
I now have the pleasure and honor to present the jewel of the crown. Actually, Hanan Ibrahim is an important person in my life. I like her ever since she was a resident in Children's Hospital. So she's doing a very good job in the intensive care unit, pediatric intensive care unit of the Children's Hospital. I'm very happy to present her. She will speak today about the pediatric invasive pneumococcal disease, and I'm sure we are going to enjoy her presentation. Please, Hannah, start.
Okay, many thanks, Professor Ilham, for this nice introduction. It's an honor to be presented by my dearest Professor Ilham Hosni. Also, I admire Professor Ilham since I was a resident also. I also thanks Professor Muhammad Atiyah and Professor Ilham for being with us in all PQ conference all over the years. Invasive pneumococcal disease, this is a lecture sponsored by Pfizer vaccine. What is invasive pneumococcal disease? Invasive pneumococcal disease is defined as the presence of strep pneumoniae from a normally sterile site, like blood, cerebrospinal fluid, pleural fluid, joint, or peritoneal fluid. Invasive pneumococcal disease is a life-threatening condition that is fatal in 10 to 15% of cases. Strep pneumoniae, as we all know, is a pneumococcus that is gram-positive diplococci with more than 90 serotypes, determined by polysaccharide composition of its capsule, and it is carried asymptomatically in approximately 50% of people. Can you imagine? نصنا تقريبا ماشي ومعاه الستريب pneumoniae. Infection usually start by dissemination of strep pneumoniae from the nasopharynx by droplet infection to go to the target organ, causing pneumonia, otitis media, and bacterial meningitis. We can classify pneumococcal disease into non-invasive, which is much more common than invasive infection, mucosal disease, pneumonia, acute otitis media, or invasive like meningitis, bacteremia, complicated pneumonia with emphysema and other complications. However, we have to know that the true burden of primary and invasive pneumococcal disease may be significantly underestimated, especially in Egypt. Why? Because of the empiric and the abuse of antibiotics and the frequent lack of cultures. Does all serotypes of strep pneumoniae are equally pathogenic? Of course not. We have a highly pathogenic serotype like serotype 3, which causes invasive pneumococcal disease, septic shock with higher mortality. Serotype 6A, responsible for MDI and causing invasive infection. Serotype 19A, which is responsible for MDR, strep pneumoniae, and embolism. Anybody can get pneumococcal disease, but some people have a higher risk of infection or its complication other than others, like whom? Like our kids, anyone under the age of 2 years or anyone more than 65 years, anyone with underlying medical condition, people with weak immune system, either congenital immune deficiency or acquired due to chemotherapy, steroids, or hatta transient immune deficiency. Those with chronic diseases such as diabetics, patients with heart disease, kidney disease, splenectomized patients, people who live in long-term care facilities, anyone who smokes, and our kids as passive smokers, kids with cochlear implant, and the people who contract another serious infection like influenza infection, like COVID-19. All these factors can precipitate to invasive pneumococcal disease. Invasive pneumococcal disease, I will talk briefly about this group of disease, starting with pneumococcal meningitis. We all know that meningitis is the inflammation of meninges that covering the brain and the spinal cord. Pneumococcal meningitis usually develops after pneumococcal bacteria present at the sustained level for 12 to 24 hours, causing cytokine release and some inflammatory mediator release and inflammation in the meninges. But the changes in the CSF can occur within hours of infection. Strep pneumoniae is the second most common cause of bacterial meningitis nearly all over the world. However, it is the first most common cause of bacterial meningitis here in Egypt. Not as we observe it only, but the study tells us so. Like this study, which is published in 2007, it's responsible for 42% for positive bacterial cases exposed for strep pneumoniae, 20% Haemophilus influenza, 17 meningococci, 17 TB, and 6 others. Okay, how it is presented? The younger the age, the difficult to recognize that the patient has bacterial meningitis. As in younger children, pneumococcal meningitis usually present with non-specific manifestations like fever, irritability, difficulty in feeding, vomiting. This is why there is a lag period between being presented and the definitive diagnosis of bacterial meningitis. However, as the disease progresses, focal neurological manifestations happen, seizures, decreased level of consciousness, and even deep coma. Older children are commonly present with classic features of meningitis such as headache, fever, neck stiffness, photophobia, decreased level of consciousness. Our nightmare in ICU is the increased intracranial tension due to bacterial meningitis, cerebral edema, focal cerebral ischemia, infective subdural effusion, or generalized even ischemia. This is a CT of the patient with frontal ischemia. This frontal lobe ischemia, however, the edema is not that extensive. This means there is vascular occlusion here due to bacterial infection. On the other hand, this picture severe brain edema. Nearly we cannot see the ventricular system, but multiple foci of ischemia all over the brain. This is due to brain swelling. We do a lot of panel of investigations actually in such cases, but we have to concentrate on the diagnostic investigations like CSF examination, PCR or culture. PCR is much more sensitive and much more specific. Brain imaging like CT scan and MRI. Of course, MRI with dye study is the priority brain imaging investigation. However, sometimes we cannot do it in emergency basis, so we have to give ourselves a picture about the patient by doing CT scan. CT scan can exclude space-occupying lesion, intracranial hemorrhage, brain edema. So we have to do CT scan if MRI is not available. Sometimes we cannot do lumbar puncture due to signs of increased intracranial tension, the patient in a bad state, shock state, severe convulsions which is not controlled, coagulation abnormality, local superficial infection with the skin at the site of lumbar puncture, severe respiratory insufficiency, At that time, we have to stabilize our patient first, then we can do the CSF examination. However, this cannot delay our treatment for the patient. How to treat? Of course, we have to treat with specific antibiotic therapy targeting to all causes of bacterial meningitis, not only the strep pneumoniae, until culture result raised up. We start with vancomycin, third generation cephalosporin, ceftriaxone. Antibiotic therapy can continue for 10 to 14 days according to the response of the patient. What about steroids? We follow the NICE guidelines and the American Academy of Pediatrics. We give dexamethasone on a dose of 0.15 milligram per kg every 6 hours for 4 days, and take care. We have to give dexamethasone just before starting antibiotics or within 4 hours of antibiotics, but certainly no more than 12 hours after initiation of antibiotics. It will be nonsense at that time. Neuroprotective measurements is very important. We have to give the patient good oxygen supply, good hemoglobin level above 10, maintain normal CO2, maintain normal blood glucose level. Head tilting is very important, and control the convulsions, of course. Pneumococcal meningitis, there is high incidence of a serious neurological consequences and morbidities. On the top of the list is the hearing loss. This is why you have to follow your patient by hearing test after recovery from pneumococcal meningitis. The mortality rate in bacterial meningitis is high, but specifically in strep pneumoniae bacterial meningitis is even higher than Haemophilus influenza by 8%. For us as intensivists, we have to know that there is a higher risk of death if children presented in a shock state or a coma or required mechanical ventilation. Here I can tell you this patient carry a bad outcome. Complicated pneumonia. Pneumococcal pneumonia is the most common cause of community-acquired bacterial pneumonia in children under the age of 2. Complications like empyema, pleural effusion, septicemia and septic shock, which is very important, and a small proportion of children may develop severe ARDS or acute lung injury. This is a chest X-ray with pleural effusion, left-sided pleural effusion. This is with ARDS, acute respiratory distress syndrome due to septicemia, due to pneumococcal pneumonia and septicemia. What about necrotizing pneumonia? Actually, this name we do not acquainted about this necrotizing pneumonia until 1994. محدش كان يعرف ان الاطفال ممكن يحصل فيه حاجه اسمها necrotizing pneumonia. What is necrotizing pneumonia? It's a type of aggressive pneumonia that causes destruction of the underlying lung parenchyma, resulting in multiple small thin-walled cavities. The cause of necrotizing pneumonia: number 1, staph pneumonia; number 2, strep pneumonia. Usually complicated with empyema. This is how it looks like. The lung is completely destructed. This is my patient, 2.5 years old girl, presented with history of low-grade fever, runny nose, cough, and easy fatigability for just 1 week. When I did this X-ray, this is how it looks. Complete destruction of her right lung. And this is the CT scan of the girl. And this is the CT scan of the girl. And it is proved to be strep pneumoniae infection. What about pneumococcal septicemia? We have a certain problem about pneumococcal septicemia. Actually, we have 2 problems. Problem number 1, sometimes it is presented without a focal disease. The patient in septic shock and you cannot find any focus. Problem number 2, it has double mortality of the bacterial meningitis, of pneumococcal bacterial meningitis. So it's a serious disease. What about other suppurative invasive pneumococcal diseases? Strep pneumoniae can cause suppurative infection in almost any part of the body, especially the abdominal infection like peritonitis, ileitis, appendicitis, which has been reported, and even multiple abscesses in solid organs. Peritonitis and ileitis are particular risk in children with nephrotic syndrome, as we all know. Other sites also reported with strep pneumoniae infection like joint, pericardium, and placenta. Hemolytic uremic syndrome is also recorded after strep pneumoniae infection. In UK, it accounts for 14% of all hemolytic uremic syndrome cases. Okay, how to prevent invasive pneumococcal disease? Such a bad disease with mortality and morbidity, we have to think about prevention. through vaccine. The first pneumococcal vaccine developed contained purified polysaccharide. However, such vaccines are ineffective in children under the age of 2 years because it is non-immunogenic to them. To protect infants at highest risk of invasive pneumococcal disease, pneumococcal polysaccharide conjugate vaccine has been developed that elicit T-cell help and effective from birth. BCV13, which is the vaccine manufactured by Pfizer, it's a pneumococcal polysaccharide conjugate vaccine involving 13 serotypes. It involved mainly the 3 serotypes that are responsible for invasive pneumococcal disease. Type 3, as I mentioned, type 6A, type 19A. In children and adolescents aged from 6 weeks to 17 years, we can give BCV13, which help to protect against invasive pneumococcal disease, pneumonia, and otitis media. To what extent it can help? A lot of studies about this subject. This is one of them. In United States, invasive pneumococcal disease caused by the 6 additional serotypes in BCV13 less than 18 years, 3 years following vaccine introduction. Here is the BCV vaccine introduced in 2010, and here is the curve of invasive pneumococcal disease. We can see it is declined by how much? By about 93 reduction in less than 5 years old infants, children, sorry, and less than 75 reduction in 5 to 17 years old children. What about 19A evolution in United States children? Total number of serotypes less than 5 years. Here is the blue columns before introduction of BCV13, and here is the green columns after introduction of BCV13, a complete reduction of evolution of 19A serotype. Okay, what is the dosing? We all know the dosing of BCV13. From 6 weeks to 6 months, it's 4 doses. From 7 months to 11 months, it's 3 doses. From more than 1 year, we can give 2 doses. More than 2 years to 17 years, we can give 1 single dose of BCV13. Okay. Concomitantly, I can give BCV13 with other vaccines like DBT, Haemophilus influenza B, inactivated polio, hepatitis B, meningococcal serotype C, MMR, varicella, and rotavirus. It has a wide safety margin. The most common adverse reaction in children 2 weeks to 5 years are vaccination site reaction, fever, irritability, decreased appetite, increased or decreased sleep. My take-home message: invasive pneumococcal disease is a serious disease with significant mortality and morbidity. Prevention through vaccination has to be mandatory, and many thanks.
Thank you very much, Dr. Hanan, for this excellent presentation. I think now we are all acquainted with the vaccine. Please, for all the attendees, if you have any questions to Dr. Hanan, please put it in the Q&A compartment of the session. Thank you, Hanan. I'm very happy now to turn the mic to my colleague, Dr. Mohammed to present coming team.
Thank you very much, Professor Ilham. I believe we have a promotional break. Is that right? Thank you very much. Let's go back to our speakers, and if I may wrap up, what we've done so far is that we had the first 2 speakers and we spoke about the silent invader, and that was with Dr. Summer and Professor Iman Ragab. Then we had the incognito enemy and how tuberculosis can be mistaken with other disorders. That was with Dr. Nihad Bakri and Professor Marwan D. Then we had an impressive overview of the invasive pneumococcal disease with Professor Hanan Ibrahim. Our last section for this evening will be composed, as you can guess, with two speakers. We'll start with the hidden mystery with Dr. Ahmed Al-Sayed, who is an assistant lecturer of pediatrics in Ain Shams University, and the comment will be to Professor Dalia El-Ghunaimi. So let us start now with Dr. Ahmed Al-Sayed. Dr. Ahmed, please.
بسم الله الرحمن الرحيم. Thank you, Dr. Muhammad. Our case presentation, the hidden mystery. Personal history: Sandy is a 3 years old girl, second order of birth of non-consanguineous parent. Complaint: vomiting and diarrhea of 3 days duration. History of present illness: the condition started 3 months before presentation, when the patient developed high-grade persistent fever associated with bilateral arthritis affecting the shoulder, the knees, and the ankle joint. No skin rash, no hair loss, no photosensitivity. She was treated empirically with antibiotic and antibiotic ibuprofen with partial improvement. 3 days before admission, the patient developed vomiting and diarrhea associated with high-grade persistent fever and jaundice. Relevant past history: a positive family history of hepatitis A. Her sister was diagnosed as hepatitis A at the same time. On examination, the patient was drowsy and toxic, feverish, high-grade fever, pallor and jaundice, chest bilateral equal air entry, heart normal S1, S2, no murmur, abdomen distended with hepatosplenomegaly without ascites, bilateral lower limb pitting edema, blue the knees joint with ecmotic patch, painful limitation of both knees joint movement. Laboratory data: TBC showed by cytopenia, anemia and thrombocytopenia, prolonged BT, BTT, and INR, normal kidney function, impaired liver function, and dependent viral markers, high LDH, high CRP, normal ESR, very high ferritin, high triglyceride, and consumed fibrinogen. Pelvic abdominal ultrasound showed mild hepatosplenomegaly, mild ascites, minimal right pleural effusion. Immunologic consultation was done. A case of systemic juvenile idiopathic arthritis with secondary macrophage activation syndrome for IVIG and steroid therapy. Patient started dexamethasone on 10 mg per meter square and received IVIG 1 gram per kg, 2 doses. Why systemic juvenile idiopathic arthritis? Due to age of onset less than 16 years, arthritis, duration of disease more than 6 weeks, characteristic persistent fever with exclusion of other form of arthritis. And why macrophage activation syndrome? Due to these criteria: fever, splenomegaly, cytopenia, hypofibrogenemia, high ferritin, and high triglyceride. Soluble CD25 was binding, and also bone marrow aspirate was binding. Viral markers showed hepatitis A positive, hepatitis B negative, hepatitis C negative, cytomegalo and Epstein-Barr was negative. Follow-up: patient conscious level start to deteriorate, glaucoma 10/15 with progressive ascites and increased lower limb edema with high serum ammonia. Serum ammonia was 100. Hepatology consultation was done. Case of acute fulminant hepatitis and hepatic encephalopathy for hepatic support and close monitoring. Management: patient started hepatic support with regular enemas, received several times backed RBCs and plasma transfusion due to bleeding per rectum without improvement. Patient developed nephritis in form of oliguria, hypertension, and proteinuria with impaired kidney function. At this time, liver transplantation was considered. Diuretics and antihypertensive added furosemide, spironolactone, captopril, and amlodipine. Cyclosporin IV added after consultation of hepatology and immunology team with marked improvement. Workup: immunological marker anti-CCP antibodies negative, ANA anti-double stranded DNA negative, very high soluble CD25, and bone marrow showed mildly hypocellular marrow with marked depression of erythropoiesis. Prognosis: patient general condition improved, normal conscious level regained, liver and kidney function test normalized, patient discharged to home. What is the diagnosis? The diagnosis: hepatitis A associated with macrophage activation syndrome in patient with systemic juvenile idiopathic arthritis. Hepatitis A virus associated with very rare reported cases of macrophage activation syndrome. Thanks to our PICU resident and our PICU nurses. Special thanks to our PICU team. Special thanks to Dr. Amal Faramawi and Dr. Dalia Helmi. And thank you to you.
Thank you very much, Dr. Ahmed. That was very clear explanation of your case presentation. And now our next speaker will be Professor Dalia Helmi El-Ghunaimi, who will talk to us about contributors to macrophage activation syndrome, which was noticed in the previous case. Please, Professor Dalia.
Thank you, Dr. Mohammed, for your kind introduction, and thank you, Dr. Hanan, for her kind invitation for me to share in this great event. My talk is about different contributors of macrophage activation syndrome. Objectives of my lecture is to identify the pathophysiology of this complex situation, identification of different contributors to the development of MAS, and be familiar with the clinical and laboratory features of these disorders, and how can we manage macrophage activation syndrome. Macrophage activation syndrome is a severe, potentially fatal condition associated with excessive activation and expansion of macrophages and T cells, leading to overwhelming inflammatory, hyperinflammatory actions and cytokine storm. In general, MAS is classified as a secondary hemophagocytic lymphohistiocytosis, but occurring in the context of rheumatic disease. It has been reported to occur with all other rheumatic disease, but it is commonly complicating systemic juvenile idiopathic arthritis. But however, cases of systemic lupus erythematosus and Kawasaki disease have been reported to be complicated with macrophages activation syndrome. How could these complex situations come to the surface and present itself? Actually, it starts with failure to deliver apoptotic signals, leading to persistent expansion of T cells and macrophages secreting pro-inflammatory cytokines. This results in self-amplifying inflammatory activity and persistent inflammatory response. This continuous inflammatory environment results in transient natural killer cell dysfunction. So if we can look at this figure, there is persistent stimulation of the cytotoxic T lymphocyte, resulting in excessive secretion of interferon gamma and granulocyte macrophages, colony-stimulating factors, which are a potent activator of macrophages and potent stimulator of differentiation of the monocytes into macrophage. The activated macrophage in turn secrete excessive inflammatory cytokines, mainly interleukin-6, interleukin-1, interleukin-18, and tumor necrosis factor alpha, together with hemostatic tissue factor, which shares in the coagulopathy characterizing this disorder. Moreover, the macrophages, the activated macrophages, express excessive scavenging receptor, termed CD163. Actually, the CD163 overexpressed over the actively phagocytic macrophages explain why this disorder is characterized by hyperferritinemia. The CD163, it's captured the hemoglobin haptoglobin complex, which is acted upon inside the lysosome by heme oxygenase, liberating free iron, which is then sequestrated with the ferritin, meaning that excess ferritin is needed in this situation. So what are the contributors to the development of macrophage activation syndrome? What leads to failure of the apoptotic signals and the persistent hyperinflammation of the cytotoxic T lymphocyte? Active underlying disease, infectious agents, and genetic background all contribute to the development of MAS. Let's start with the active inflammation. The majority of macrophage activation syndrome occurring during active disease or at disease onset, meaning that it's before starting or with starting treatment. So the immune system is hyperactive, not controlled. There is excessive production of different pro-inflammatory cytokines during the disease activity, and it was found that the persistently high level of interleukin-6 result in excessive production of pro-inflammatory cytokines and chemokines by activated macrophages, some sort of vicious circle, and ending in transient defect in natural killer cytotoxicity, resulting in persistent antigen stimulation and failure to kill the target cell or the self-antigen inciting the immune response. So coming to the infectious agents, the most prominent infectious agents involved in macrophages activation syndrome or secondary hemophagocytic lymphohistiocytosis, and even in the primary hemophagocytic lymphohistiocytosis is virus, and namely herpes virus are the most common, predominantly Epstein-Barr and CMV, but also herpes simplex virus and varicella zoster virus. These are DNA virus that are very potent modulator of the immune response. Less frequently RNA virus, including different strain of influenza, HIV, dengue, hepatitis C, and actually hepatitis A virus is reported to few cases all over the world inducing macrophage activation syndrome. It's not only virus, but less commonly could be protozoal, could be mycobacteria, could be Pneumocystis cerevisiae. Other organisms can induce, but much less common than the viruses. Let's see this figure, how viruses contribute or predispose to the development of macrophage activation syndrome. How do they work on the immune system to change it into a cytokine storm producing persistent inflammation? So the virus can result in sustained infection, sustained pattern recognition receptor stimulation, namely toll-like receptor and node-like receptor, resulting in a persistent immune system activation. Also, it leads to suppression of the natural killer and cytotoxic lymphocyte cytotoxicity, and this is through inhibition of certain activating ligand to these cells, and decreasing some sort of peripherin expression and certain other protein involved in the apoptotic pathway in the natural killer cytotoxic T lymphocyte. Sometimes the viral, instead of or in addition to infection of the classic cell, they cause infection of key HLH cell types like infection of the dendritic cells, infection of the macrophages, infection of the natural killer cells themselves, so disturbing the immune response. They escape the natural killer cell and cytotoxic T lymphocyte recognition, so they maintain infection and stimulation of the immune system, inhibition of apoptosis, so maintaining long-lived infected target cells, and interference with the host cytokines and chemokines balance through the virus itself secretes certain virokines and virochemokines which interfere with the host cytokines and chemokines, leading to suppression of the key cells of the involved in the apoptotic pathway and contraction of the immune response. So why the virus in a specific host resulting in this picture or this phenotype? It is very much related to the high viral load, and we can see with the COVID as we see these days. High viral load is associated with stress, chronic stress on the immune system, and different mechanism evading the normal immune response to control and contract the immune response. Also, subclinical genetic defect in the immune cells is highly suggested in these patients. So what about the genetic background? Some patients with macrophage activation syndrome complicating rheumatic disorder were found to have hypomorphic variants or heterozygous mutation in one or more of the known genes of the genes known to cause primary hemophagocytic lymphohistiocytosis. However, unlike primary hemophagocytic lymphohistiocytosis, the genetic effect in macrophage activation syndrome is predicting the risk of recurrence, not affecting the phenotype. So it is not about like the primary hemophagocytic genotype phenotype, but rather it is predicting that this patient is at risk for recurrence. And we can say that this girl, Sandy, she deserves genetic testing. So as we can see, is this patient at risk for recurrence or not? Being the trigger to cause macrophage activation syndrome in this case is the uncontrolled activity of the disease and the hepatitis A virus, although hepatitis A is known to be a very rare trigger for macrophage activation syndrome. And we can see that her sister passed very normally without any complication. So it is not only about hepatitis A virus, she must have another additional factor that results in this drastic presentation. The clinical features, these patients, as I said, mainly presenting with underlying active rheumatic disorder. They have equal frequency and incidence on boys and girls, no racial predilection, and can occur at any age. Patients with a chronic condition become acutely ill with persistent fever, mental status changes, hepatosplenomegaly, and lymphadenopathy. The patients might present with pallor, anorexia, so chronic patients acutely deteriorate, and you cannot correlate only this to the underlying active disorder. Mental status changes, seizures, and coma are most common seen as manifestation. It can involve the cardiopulmonary system with pericarditis, acute dilated cardiomyopathy, and up to ARDS, hemorrhagic skin rashes, up to hematemesis, and rectal bleeding. And this girl had hematemesis. Renal involvement, oliguria, acute renal failure, nephrotic syndrome, and this patient has nephrosis and some sort of nephritis associated with the macrophage activation syndrome, because it's after resolution of the macrophage activation syndrome, everything returns back to normal. So it is not related to the fulminant hepatitis. It is not related to the systemic GIA. Once macrophage activation syndrome is controlled, everything back to normal. Transient uncharacteristic skin rash and maybe panniculitis. We have to know that these patients are at risk for mild subclinical mass, which can occur in as 1/3 of patients with active systemic disease. How can we detect this? If a patient with systemic GIA or with active rheumatic disorder, and then his lab, he maintained his clinical presentation of the underlying disease, no change in the clinical features, but when you follow up his lab, you found that his platelet was like 700,000 and then dropped to 400,000, and still he's suffering of activity. There is no control of his underlying disease. Mean that the drop of the platelet count is not related to control of the disease, but it is related to a simple underlying active process, ending might be into macrophage activation syndrome. The patients have cytopenias, mainly affecting the platelets and erythrocytes. Some patients with systemic GIA maintain the leukocytosis at presentation. With disease progression, they turn to be pancytopenic. With the occurrence of coagulation, they have prolonged PT and PTT. The ESR is either low or normal, like we see in this girl, and it is related to the degree of hypovibrinogenemia. CRB is persistently high. If you can see the blood chemistry going into the liver affection, we will see elevated serum transaminase, hyperbilirubinemia, hypoproteinemia, hypertriglyceridemia, hypofibrogenemia. We can see that if macrophage activation syndrome is that the classic affection of the liver, we can see that it does not end in fulminant hepatitis, and serum ammonia is either normal or mildly elevated. In this girl, the condition worsened rapidly because there are different hitters for the liver, the macrophage activation syndrome, the hepatitis A, and the systemic GIA activity itself. This patient have elevated ferritin, and we can just, if we remember that I explained why, because the activated macrophages display CD163, which is a scavenger for the iron to be bound to the ferritin instead of being free, to decrease the oxidative stress. Renal affection could occur, elevated D-dimer, and elevated LDH. Histopathological examination, virtually every organ can be infiltrated, but very commonly the bone marrow and the lymph nodes to be accessed. We will see tissue infiltration with T lymphocyte, actively phagocytic macrophages, and we can see hemophagocytosis, but absence of hemophagocytosis does not exclude the disease. And histological evaluation of the liver per se, because of macrophage activation syndrome, shows severe diffuse fatty changes in addition to infiltration with active macrophages in the sinusoidal and periportal areas. We can see in the CSF moderate pleocytosis, immunological biomarker. This is a promising biomarker concerning accessing the soluble CD163 and measures the cytokines interleukin 18, interleukin 6 mainly. However, elevated soluble interleukin-2 receptor alpha CD25 is now available, and it is one of the criteria of the HLH 2004 classification criteria for primary hemophagocytic lymphohistiocytosis, but it is not available in all lab. So can we simply just apply the revised diagnostic guidelines for HLH 2004 on patients with a childhood rheumatic disease concerning the clinical presentation of fever, splenomegaly, and the lab presentation of cytopenia, hypertriglyceridemia, hemophagocytosis, lower absent natural killer cell activity, ferritin, and elevated soluble CD25? These are very informative diagnostic criteria, but macrophage activation syndrome, although have similarities with the primary hemophagocytic lymphohistiocytosis, but it's some sort differ in the inflammatory, severely inflammatory background, and that fibrinogen and platelet count commonly affected very late in the course of the disease because they act as acute phase reactant. So in SLE, for example, autoimmune cytopenias are common and difficult to be distinguished from cytopenias caused by mass. How could we suspect macrophage activation syndrome in a patient with SLE? If we can find that the patient's turned to have persistently high fever, increase the degree of malaise, and although he showed manifestations of uncontrolled disease, he has low ESR. Also, extreme hyperferritinemia and LDH elevation would further support the diagnosis. So what about systemic GIA and other systemic vasculitis? They have leukocytosis, thrombocytosis, increased fibrinogen level, and other acute phase reactant. How we can solve this problem? If I found that the decrease of the total leukocytic count and platelet count below the expected value for the disease, even if it is still within the normal range. I mean, if a patient systemic GIA came and he has fever, okay, and his platelet count was 200, okay, this is normal, okay, but still it is not normal at all for a patient with systemic GIA. If I search for the patient has fever, there is a conjoint work between the EOLAR, ACR, and BRAIN2 to put a classification criteria for a mass in GIA. So they suggest that if a patient suspected, there is no need to be confirmed, even if suspected systemic GIA, it means you exclude infection, exclude malignancy, and you found that he has persistent fever and serum ferritin exceeding 684, and any two of the following, platelet count less than 181, AST more than 48, triglycerides more than 156, and look at the fibrinogen, they put a higher threshold than that used by the HLH 2004 classification criteria. Why? Because fibrinogen is acute phase reactant in this disorder. We have in these patients to exclude infectious causes or familial hyperlipidemia. So what about treatment? This is a life-threatening situation, and we can see we have to give high-dose corticosteroids, pulsed methylprednisolone, aiming to control the cytokine storm and as well as to control the disease activity. If the things is controlled, we can give oral steroids. Some patients with moderate cases, we can start with dexamethasone. Parental administration of cyclosporin A is very effective, causing very rapid improvement within 12 to 24 hours from initiation, and then to be followed by maintenance oral cyclosporin A. Cyclosporin should be gradually tapered off and not suddenly withdrawn, because it can result in relapse. But unfortunately, this is not the story in every patient. Some patients are resistant to the steroid and cyclosporin. We, as a pediatric immunologist and rheumatologist, we do not favor etoposide, but we are obliged to use in resistant cases, and it is used in the same doses and same regimen as the HLH 2004 treatment protocol. Coming to the biological therapy, in patients, some certain prefer to use anti-thymocyte globulins instead of etoposide in steroid and cyclosporin resistant cases. Intravenous immunoglobulin may be beneficial if it is driven by viral infection, as our case. I prefer to give her intravenous immunoglobulin together with dexamethasone. Anti-CD20 monoclonal antibody, rituximab, in case of Epstein-Barr virus-triggered mass. Some case report investigating the role of interleukin-1 blocking therapy, anakinra and canakinumab, interleukin-6 receptor antagonist, tocilizumab, and JAK inhibitor, toftinib, as a part of to suppress the STAT and suppress the vicious circle of T-cell activation and macrophage activation. And it is very important that we use it as a step approach. Okay, so in primary HLH, they use the whole protocol, dexamethasone and etoposide at the same time. But in macrophage activation syndrome, we use steroids. If controlled, okay. If not controlled, like this case, we resorted to adding cyclosporin intravenous. If not, we add other drugs. I would like to acknowledge my team in the pediatric allergy immunology unit, founded by our beloved Professor Dr. Yahya Al-Gamal, and headed now by Professor Dr. Shireen. I'm very thankful and appreciating all their effort to give the best for our patients. May Allah cure them all, and thank you for your attention. Thank you so much.
Thank you very much, Professor Dalia El-Ghonaimi, for a very scientific presentation. That was really elaborate and really educational. Before we start our question and answer session, may I convey to all our speakers very positive comments coming through the chat section of this evening, very acknowledging to the program, to the topic selection, and to actually the conduct of the presentations. This evening we had more than 350 participants. I could spot them from all over Egypt, from Saudi Arabia, from India, from the States, and from Canada, which is really impressive. And I'd like to congratulate the organizers for a very successful evening. I'll hand over to my dear colleague, Professor Ilham, to start the question and answer session on the first segment of the evening.
I echo the nice words of my colleague, Dr. Mohammed Bayoumi. Really, this was a very beautiful session. I'm happy to participate in. We have some questions for the first, which is headed by Dr. Iman and Dr. Samar. The first question is, yes, from Dr. Walid. Excuse me?
دكتور إلهام، أنا دكتور طارق.
أهلا يا طارق.
من فضلك بس أنا عايز أوجه خالص الشكر للمجموعة الرائعة اللي عملت بالنهارده بالمؤتمر. حقيقة أولادنا كانوا على قد المسؤولية، والسادة الضيوف كانوا قدموا سيمفونية رائعة من العلم الجميل. أعتقد إنه أمتع الجميع. ما كانش الموضوع ممكن يتم لولا القيادة الحكيمة من الأستاذ الدكتور إلهام حسني والأستاذ الدكتور محمد عطية. أنتوا حقيقة شرفتونا ورفعتوا من قيمة المؤتمر، فأنتوا وجودكم في حد ذاته يعني بيرفع قيمة وبريق أي مؤتمر. كنت لازم أتكلم وأوجه لكم خالص الشكر، والشكر لولادنا حقيقة وضيوفنا على أعمالهم. فخالص الشكر والتقدير لكم جميعا.
Thank you very much Professor طارق صديق العمر يعني. الحقيقة عندنا شوية questions هنبتدي بيها لدكتورة سمر ودكتورة إيمان رجب. الفيرست تيم دكتور وليد حسن بيسأل did you do HIV? Did you investigate your patient for HIV?
And it was negative, doctor.
Negative? Okay.
Yes.
And then there is a question from Professor Sahin, and we are very happy to have her with us tonight. She's asking, did you do can we do surgical excision and biopsy of the fungal lesion in this patient? Did you consider this?
Yes, we did ENT consultation, neurosurgery consultation, ophthalmology consultation, but unfortunately...
Please raise your voice, Sahar, please.
We did ENT consultation, and unfortunately the lesion was invasive, so invasive, and the general condition was so bad, so they decided to do no intervention.
Okay, and then
comment about this.
Okay, go ahead, Dr. Iman.
In mucormycosis, because of the poor response to antifungal agents, the surgical treatment is very important. So whenever we can do as debulking as we can, we would go for this, not only for diagnosis but also as a curative intent.
Yes, and if you allow me to comment, we have a patient with CARD9 deficiency, which is one of the innate immune defects, who had invasive fungal infections, and every time we had to do debulking before starting posaconazole and itraconazole as treatment. Debulking was a good in this patient. Okay, Osman from Asyut is asking what about the long-term fungal prophylaxis in primary immune deficiency patients? Do you do this? And what would you recommend for Iman?
Fungal prophylaxis, whenever there is frequency of fungal infection presumed to be more than 7 to 10%, we have to do fungal prophylaxis. The type of fungal prophylaxis depends on the frequency of the encountered fungi. If it's common to have Candida albicans, we go for fluconazole. Probably in this era, because of the predominance of the non-albican species and the aspergillus, it's better to use Vari or micafungin according to the admission status of the patients. Vari predominates because of the available of the oral form, but I said in the presentation, we have sometimes to do MTD, therapeutic drug monitoring for the patients. So yes, whenever it's sometimes indicated, but according to the policy of the institution.
Okay, and then Dr. Tariq Atiyah is asking, is it better to diagnose CNS fungal infections by MRI or CT? What modality that you would prefer?
The MRI is more important because the fungal infection metabolizes with the iron. So sometimes they use the T2 star. We use it in the thalassaemic patients. So it is used in fungal infection because there is iron deposition inside the fungal balls inside the brain. So whenever it's present, it goes in favor with the fungal infection, but for sure the sure diagnosis is by biopsy. It's not by radiological, only inside the brain, specifically for the brain lesions.
Okay, Dr. Ghulam Nabi, he's a pediatrician from he's very happy with the presentation, Dr. Samar, and he's asking about some points about the fundus examination of the patient, lumbar puncture, the blood culture, and the immunodeficiency. He said it should present early in life, and this argues against this in this patient. But there are, Dr. Ghulam, allow me to answer you this because I'm an immunologist. There are immune deficiency disorders, primary immune deficiency disorders that begin late in life. Some of them innate immune system, such as the CARD mutations, and so the common variable immune deficiency. Sometimes it presents even in adulthood. So what would you would like, Dr. Summer, about the fundus, the lumbar puncture, and the blood culture?
Blood culture was not gross. The fundus was done, and there was signs of increased papilledema with signs of increased intracranial tension. Lumbar puncture, we couldn't do it.
Okay, Dr. Hanan, concerning your presentation, Professor Hanan Ibrahim, there is a question: could pneumococcal infection be a common co-infection in COVID-19? Dr. Hanan, please.
Yes, it is. And there are many articles about secondary bacterial infection with strep pneumoniae in COVID-19 patient. But I cannot tell. We have to give the vaccine for the population to avoid this, because the mortality rate from COVID-19, not only from the secondary bacterial infection, it's from many, mainly from cytokine storm and many other issues.
Okay, another question, Dr. Hanan. Is pneumococcal vaccine in the Egyptian vaccination schedule? I think he means the expanded program on immunization in Egypt.
I think the Ministry of Health, it is not an obligatory, unfortunately, it is not there. It is not an obligatory vaccine. But kids, we deliver this for the kids in private hospitals and the private clinics, but it is not in the obligatory vaccine.
An anonymous attendee is asked, is pneumococcal vaccine different types are interchangeable, or what guide to do? I think he means, can we use each every time?
I don't like to do this. No, it's not interchangeable. If you started with one, you have to continue with that one. Except if the other one is not available, you can give the extra dose with the second one you started with.
Okay, these are the questions that I have, and then I hand the mic to my colleague, Dr. Muhammad Atiyah, for the sessions he presented, so he can ask their questions.
Thank you very much, Professor Ilham. We'll actually start with questions and answers for the session by Dr. Nihad Bakri and Dr. Marwa Eldib. And I believe, Professor Ilham, you yourself have a comment, so let us start with your comment.
Okay, I just want to say that I have seen the patient Joseph, the boy with the tuberculosis, and I was consulted for this patient as an immunologist when they thought that this could be something autoimmune. And I gave the diagnosis of tuberculosis from the beginning. We don't want to forget the basics. The message that I want to deliver to our young colleagues, that please think basic. You have a child that is cachectic, has chronic diarrhea, and there is both pleural and pericardial effusion. You have to think first what is common in our country. So I thought of tuberculosis. I asked for the quantiferon, and I called the chest hospital to ask them for a therapeutic test in this, if they can give us anti-tuberculous medications, even to start as a therapeutic test. So I'm happy the patient is fine when I saw his photo here in the, in the session.
This is very, very intelligent remark, Dr. Ilham, dear professor, of course, because yes, I highlighted that in this very patient, the presence of effusions is more towards the tuberculous side. So that's very intelligent. We should always trust our clinical sense, and we'll be lucky if we can, if we can consolidate this with other lab and imaging and histopathology, we'd be very lucky. But number one is the clinical suspicion. That's in every protocol for management. Thank you very much.
Before jumping into remote diagnoses and rare diseases, we should think of the most common in our country.
Yes, yes, it's a very interesting case and very interesting remark. Thank you very much.
Thank you.
Thank you, Professor Ilham and Professor Marwa. I tried to group the questions because looks like your presentation has evoked so many questions. So the first item of questions, Professor Marwa, is actually about the diagnosis of tuberculosis. So many questions asking where is Zell Nelson in what you've discussed? Where is the TB culture? Have you tested the peritoneal fluid and precordial fluid using PCR testing? Would you still rely on the presence or absence of a BCG scar when you're considering the diagnosis of tuberculosis? And whether there are any precautions you need to consider before actually making or taking the quantiferon test. So it's basically about those historical elements of the diagnosis, the tuberculin, presence of a scar, the PCR, is it still there? Would you test the effusion fluids? So can you elaborate on that?
Okay, I will elaborate on the parts I know of the story, and I leave the rest to Nihat to comment. But the benchmark here is that there is no standalone test to diagnose TB. We don't have a single test that can prove or rule out tuberculosis, especially in cases with abdominal or intestinal tuberculosis. So I would second what Dr. Ilham said, that first we should have a very strong clinical suspicion. This is number one. If we are lucky enough to support this with a positive culture, a positive smear, a positive PCR, so we're very lucky. Because it's not as plain as simple as what's written in the books. It's not always there. It's not easy to culture the acid-fast bacilli. It's not easy to do PCR and find out positive tests. We've done, and Nihat have highlighted the WHO standard testing for tuberculosis, the gene expert test on the pericardial effusion fluid. They did it, and it turns out negative in a patient who's highly suspicious to be TB. So that's what I want to highlight. It's number 1 in 10, your clinical suspicion and your follow-up that will prove if you're right or not. And I think Nihat can tell us more about the investigation which were done to this boy.
Yes, of course, dear professor. At first, we do Zell Nelson stain from precardial effusion, which was negative. And start empirically steroids and colchicine to halt this inflammatory process, but still no improvement, and the patient suffered from high-grade fever. Also, we did the blood culture and focused to tell us about the TB in blood culture, but it was negative. The patient received all his vaccines and have TB scar. That's first let us to search for other causes and don't focus on infection alone. We did all investigations to cover all points of differential diagnosis. Yes, we suspected at first TB, then excluded other causes of infection and put in mind inflammatory process, like inflammatory bowel disease. And the last decision was to do quantiferon and GIT endoscopy. The surprise wasn't quantiferon was positive. Even it was undetermined, but the patient show marvelous improvement within 1 week, no fever, and improvement of his appetite.
So this effect, Dr. Muhammad, this effect is the perfect response. If you get a positive, what I could say a therapeutic test, but it should be maintained because all anti-tuberculous drugs have an anti-inflammatory effect. And that's why the response should be monitored over not only 1 week, it should be sustained over a few months. And I believe this is what happened with this patient. So the response here, the clinical suspicion and the response, I believe these were the hallmarks.
Right. That's very clear, Professor Marwa. And this will take me into the next question, which was by Dr. Nagla Othman from Asyut.
Yes, I know Nagla.
Who is sending her greetings to your person. And she's actually asking, what did you use for the treatment of tuberculosis in this child? And when you start an empirical or a therapeutic trial, would you use 2 drugs or 3 drugs, and what do you use?
The standard is to use 4 drugs. The standard first, in the start of the 2-month therapy, we used 4 drugs, the rifampicin, the INH, the pyrazinamide, and ethambutol. This is the standard, and then if the response is adequate, we continue for 12 or 12 or 18 months on INH and rifampicin. I'm not sure, Nihed, specifically what did this patient receive, but the standard is to start with 4 drugs at the very start of 2 to 3 months, and follow up the clinical and histopathological response. So this is the standard algorithm.
Even if you're starting the trial, you will start with 4 drugs. So that's clear for everyone.
That's what I believe, and that's what's written in the algorithm. I don't know how did they follow.
I'm not arguing. I'm trying to make it.
No, I'm not. I'm just saying, yeah.
For our participants.
No, it's only that I'm not sure what they did in this very patient. If he received 4 drugs or not.
Can answer what this patient.
Yes. Nihed?
Yes, actually, the patient received rifampicin, INH, pyrazinamide, and ethambutol as a trial in first 2 months, and waiting for his follow-up.
Yes, that's the standard, and that's perfect.
That's brilliant. So I think that will answer the question on the treatment of tuberculosis. There is another group of questions coming, for example, from Ahmed Nabil Abdelhadi Al-Khatib, and those questions are concerned with the diagnosis of typhoid fever. Would you still use blood cultures? How much would you believe your Vidal test? How would you diagnose your typhoid fever? Let me generalize the question to get the maximum benefit from your presence with us.
Okay, how can you diagnose typhoid fever? Diagnosing typhoid fever is very challenging, because we could not depend on the standard cutoff values for the serological testing for Vidal. Even in interpreting the Vidal test, it's written that you have to consider how much endemic the typhoid fever is in our community. And actually, I believe that we find typhoid fever everywhere. So I believe that putting typhoid fever on top of the differential diagnosis list in this patient in particular will not be a very, not possible, but it won't be a very plausible diagnosis. Of course, the need for blood culture to confirm is important, but I personally wouldn't put typhoid fever on top, especially with a whole list that Nihat showed of false positive Vidal results on top in patients with TB and in patients with inflammatory bowel disease. So yes, we could not rely only on serology.
Away from this particular patient, when maybe the clinical picture was pointing towards another side, if you're really clinically suspecting typhoid fever, what would you rely on? Or would you culture this?
I would rely on clinical presentations. Excuse me?
Would you culture the stool? Would you culture the blood? Would you go for rising antibody titer? What would you do?
I would go for cultures. I won't really go for serology. I would go for cultures.
Thank you very much. That's a very clear answer. There was the last question, whether there are any precautions before doing the quantiferon test.
I hope I could answer this question. I don't know. I'm not technically aware. I'm not technically aware. Maybe Nihed will have an answer.
Thank you very much,
I don't know.
Marwa. Thank you very much, Dr. Nihat. That was a very interesting question and answer.
Thank you very much.
Session. Thank you. That was very useful for me personally.
Thank you. This is very humble of you, Dr. Mohammed. Thank you very much.
We'll now shift to the question and answer session for our last segment, which was eloquently presented by Dr. Ahmed Al-Sayed and Professor Dalia El-Ghunaini. And I'll start with a question that's dear to my heart. When would you suspect macrophage activation syndrome in the critically ill child, especially when the manifestations might overlap with other manifestations in this cohort of patients? So if Professor Dalia or Dr. Ahmed can take on this.
Okay, Dr. Mohammed, macrophage activation syndrome, because it's very challenging, it should be always in our minds so we can see it and suspect it. So if a patient critically ill because of sepsis, severe sepsis, or as we see the cases of COVID admitted in the ICU, and we have that the patients turn it to be clinically have persistent fever, deteriorating, The fever is persistent, and although in spite of the presence of fever, the ESR is dropping down. Is not high, but it is decreasing. If we have some sort of increasing the size of liver and the spleen, we have to suspect and to do the panel for diagnosing macrophage activation syndrome. Although that ferritin is acute phase reactant, is typically increased in many inflammatory conditions, including the patients with sepsis, including with patients with COVID. But if we see that with the increase of the ferritin, the platelet is going down, the total leukocytic count is going down, the fever is protracted, the ESR is going normalizing or very low, we have to suspect macrophage activation syndrome and to treat accordingly, because this is, as we can see, this is the drastic end stage of systemic inflammatory response. If systemic inflammatory response did not stop and it is not did not be interrupted at a certain stage, uninterrupted cytokine storm that will end into multi-system organ failure will end. So we have to suspect protracted fever, increasing size of the organ, and although ESR is going down, platelet is, although it is acute phase reactant, but it is going down, we have to do the panel of soluble CD25, we have to do triglyceride, we have to do fibrinogen to complete the action. And we hope that if it is for any reason possible, we can do bedside bone marrow aspiration. It will help a lot.
That's very clear, actually, Professor Dalia. It cannot be more clear than that. And I believe you've answered another question that came through from Walid Hassan, asking whether macrophage activation syndrome can be considered as a cytokine storm. So you've clearly answered that.
Definitely, macrophage activation syndrome is the worst cytokine storm. It is the worst cytokine storm, and COVID severe cases started with systemic inflammatory response. And then if it is not interrupted, and there is reported cases of macrophage activation complicating COVID, because certain it is reported, maybe patients died early here before the diagnosing macrophage activation syndrome, but we did not do histopathological and post-mortem study to see whether there is hemophagocytosis evident in the tissue of these dead patients or not. Maybe a significant proportion of them entered already in macrophage activation syndrome.
You're making my job easy, because again you've answered another question that came through from Mustafa Abdelmordi, asking whether COVID-19 can cause macrophage activation syndrome. So the answer is yes, Mustafa, it can. The professor has already answered.
Dr. Muhammad, we have to know that macrophage activation syndrome, macrophage activation syndrome is a term used to describe secondary hemophagocytic lymphohistiocytosis complicating rheumatic disease. In a COVID, it is termed secondary hemophagocytic lymphohistiocytosis. It is not macrophage. It is just names. It is just describing, but it is the same underlying mechanism. But we have to believe that any inciting agent could end in hemophagocytic lymphohistiocytosis.
Right. Again, you're answering unasked questions on my list, because there was a question from Hind Ahmed asking what's the difference between HLH and MAS. So you've already answered that. Thank you very much. That it's something like the common final pathway for so many etiologies.
Yes, Dr. Muhammad, it's when they classify first hemophagocytic lymphohistiocytosis, they found that there is syndromes with a strong genetic basis, whether it's a familial type and others that associating primary immune deficiency. And there is sporadic cases that complicate infection. They classify the secondary causes to rheumatic disease as macrophage activation syndrome.
Right.
Just named.
Continue answering the questions. I'm really impressed, because there was another question asking whether there was a genetic background for macrophage activation syndrome, and you answered yes.
Okay.
Yes, I have said in the lecture that there is a genetic background for macrophage activation syndrome, but this genetic background is not like the familial hemophagocytic lymphohistiocytosis. It does not determine the phenotype. It determines the risk, the susceptibility to cause secondary hemophagocytic lymphohistiocytosis. Unlike the familial and genetic cases, the familial and genetic cases, there is genotype-phenotype correlation. Certain mutations are affecting the phenotype, being more severe, occurring at earlier age, resistant to treatment. But in macrophage activation or secondary hemophagocytic, there are a genetic background that just lead to the susceptibility of the person to the disorder and indicate he is at risk for recurrence.
That's brilliant. The next question actually comes from Dr. Sahar Hassanein, asking about the origin of neurological manifestations, whether it is can be attributable to vasculitis or is it some sort of demyelination?
Actually, Dr. Sahar and Dr. Muhammad, in hemophagocytic lymphohistiocytosis, both there is a cytokine storm and infiltration of the tissue by activated cytotoxic T lymphocyte and macrophages, with production of severe pro-inflammatory cytokines and affection of the vascular vessels. So the inflammatory cytokines will induce damage of the tissue itself. So it can induce like encephalitis. It can induce peripheral neuropathy, and moreover, it can induce endotheliitis and vasculitis because there is inflammatory cytokines and infiltration by the activated damaging immune cells.
I think Ahmed wanted to answer this.
Okay. Dr. Ilham, in this case, or in our case, conscious level affection due to hepatic encephalopathy. The patient developed hepatic encephalopathy and grade 3 hepatic encephalopathy.
Right, okay.
In our case.
So didn't have really a localizing neurological disease on imaging or something. Was a diffuse neurological disease.
No, doctor, excuse me. I'm sorry, Ahmed, I will just answer this because this patient with, when starting to proceed into fulminant hepatitis, serum ammonia going up, and just improving with the conservative management up to they think about liver transplantation. But my opinion is control macrophage activation syndrome, and inshallah, everything will return back to normal, and this is what happens.
Yes.
When we started Send-Immune, IV Send-Immune, within 24 hours, everything regressed back towards normal. So it is not about permanent damage, it is just inflammatory cytokine. If I catch the patient early, inshallah, the prognosis will be very good.
Right. The question before last, you will be happy to know that I have only 2 more questions for you. The one before last is about subclinical macrophage activation syndrome. How would you elaborate on that?
It is just an example when I'm giving the lecture. If I will just demonstrate by an example so as to be easy to be caught. If you have a patient systemic GIA and he's started with a total leukocytic count 12,000, and his hemoglobin was 9, and his platelet count was 600,000. And then he came to you subclinical, no clinical presentation, no persistent fever, no increase in the liver and spleen. But when you do a follow-up, you found that the platelet count dropped to 350,000, and the total leukocytic count dropped to 6,000. Then you ask the patient about the fever, it is still occurring. The arthritis is still present, okay? So the improvement in the CBC is not due to control of the disease. He still have an active disease, no symptoms suggestive of macrophage activation syndrome, but you can detect it by the lab when you found that there is decrease in the blood element without any improvement in the underlying disorder.
That's very clear and obvious, and a smart remark for our junior doctors to switch the brain on while looking on the follow-up labs of our patients, actually. The last question, or a group of questions on treatment, Professor Dalia, people are asking about doses of intravenous immunoglobulin duration of treatment of cyclosporin, and whether you would prefer dexamethasone or pulse sodiumidrol. Those are the questions which came through from Ines Muhammad Meni.
So concerning the intravenous immunoglobulin use, its use is just reported in some cases, and we prefer to use it in case of infection triggering the secondary hemophagocytic lymphohistiocytosis or the macrophage activation syndrome. We use it in doses as blocking antibodies, meaning 1 to 2 grams per kg. Okay, it's like the dose used in Kawasaki disease. I'm not used as a prophylaxis for infection. We use it as blocking antibodies. And it is not a guidelines. It is just expert experience, and it is resorted when you found that the patient has infectious agent and you are going to give immunosuppressive therapy, and there is a well-defined blocking role for the intravenous immunoglobulins. So it is better to combine all weapons when you are facing a drastic enemy. Second, concerning the duration of the cyclosporin, it should be for 8 weeks. Like the protocol for HLH, we are not continuing as a maintenance treatment, but as I said, that abrupt stoppage of cyclosporin will lead to marked relapse of the conditions that might be resistant to the steroid and cyclosporin when you initiate it, and you expose the patient to higher risk. So keep the immune system stabilized for 8 weeks and then gradually withdrawal. It is just as a rule, no immunosuppressive are stopped suddenly. It should be gradually withdrawn. The last is whether to prefer dexamethasone versus solimedrol. We know all that dexamethasone is the drug of choice in the HLH protocol treatment, but in our patient, if we have severe disease activity, combining the macrophage activation syndrome, dexamethasone limit our steroid dose. Dexamethasone, its dose is 10 milligram per meter square. I cannot increase than this. So if I have severe disease activity, I need to give pulsed solimedrol because it allows higher doses in short duration.
And it will control the rheumatic activity as well.
Right, okay. I have to say I'm speechless this evening. I'm very thankful to all.
Dr. Mohammed, thank you, Dr. Ilham. We are very happy with you, Dr. Tariq, Dr. Hanan, and all the team. Thank you so much.
Thank you, Professor. We've enjoyed all. I personally enjoyed all the speakers. I'd like to thank the whole magnificent team of Ain Shams pioneers, Professor Tariq, Professor Hanan, Professor Mervat Mansour, and everyone. I enjoyed all these sessions. And I leave the final closing remarks to Professor Ilham Hosni, please.
I echo yours, and I'm very proud of our young generations and all the Ain Shams team, and I am very happy with the company of my colleague, Dr. Muhammad Atiyah. I hope you like our team of professors from Ain Shams.
I already like them. I already like them.
And we like to back Dr. Muhammad.
We consider you one of us.
Yeah.
Consider you one of our family. And now I would like to turn the mic to Dr. Hanan Ibrahim, the mic of this session and of the PQ unit of Ain Shams to close the session with her lovely remarks. Dr. Hanan.
عايزة أشكر كل ولادي السبيكرز كلهم أجيال اتعلموا معانا واشتغلوا معانا بيكيو منذ أن كانوا نواب صغيرين في الرعاية. الدكتورة إيمان والدكتورة داليا والدكتورة مروة، يمكن إيمان رجب ومروة وداليا كانوا مع بعض، يعني كانوا
أنا حاسة إن إحنا قاعدين في الاستقبال.
والثالثه كانت في الاستقبال.
ايوه
انا فاكراهم الحقيقه.
احنا كبار قوي يعني، لكن دي الحقيقه مش هنقدر نهرب منها. و I am very proud of them الحقيقه. يعني احنا الجنريشنز بتسلم جنريشنز، جنريشنز بتسلم جنريشنز، وعلشان كده احنا بندي تشانس وهم قد التشانس دي انه دايما يكونوا موجودين ودايما نسمعهم ويسمعونا. هم بقى كمان بقوا اشطر مننا جدا.
العفو دكتوره حنان. Thank you for the trust.
انا سعيده لوجودهم معانا، وسعيده جدا جدا ان اداره الجلسه دي كانت في ايد استاذتنا الغاليه الاستاذه الدكتوره إلهام حسني. ياما اتعلمنا منها منذ ان كنا نواب صغيرين، والاستاذ الدكتور محمد عطيه اللي هو معانا سنه ورا سنه من ساعه ما ابتدينا نتكلم بيدياتريك اي سي يو. قد يكون ما حدش يعرف ان الاستاذ الدكتور محمد عطيه اول حد يعمل حاجه اسمها مؤتمر رعايه مركزه للاطفال في مصر. فالشيء بالشيء يذكر، يعني هو اللي حمسنا ان احنا نعمل كده. فاشكركم. الجلسه كانت فيري فروتفول، الجلسه كانت فيري بينيفيشال. مش عايزه اقول لكم الفيدباك اللي جايين على الجلسه على الواتساب وعلى الفيسبوك، الفيورز شكلهم ايه وبيقولوا ايه. اتمنى ان انتوا دايما تكونوا معانا سنه ورا سنه، واتمنى ان احنا نتشارك مع بعض الخبرات ويكون عملنا ده صدقه جاريه لكل الناس اللي هيسمعونا. وكان المفروض الدكتوره ميرفت تبقى معانا عشان تعمل الانونسمنت بتاعت الجلسه بتاعت بكره، لكن احنا هنقفل الجلسه. نقول بكره ان شاء الله ميعادنا الساعه 8. جلسه اكثر من رائعه. مطلب جماهيري هنتكلم على السيكريتس اوف راديولوجي في البيدياتريك اي سي يو. الولاد كلهم بيطلبوا وكل اللي هيكلموا اساتذه راديولوجي وانترفنشنال راديولوجي. فنتمنى تواجدكم معانا، ونتمنى كل يوم يبقى احلى من اليوم اللي قبله. and I'm very thankful to all the speakers وكل المودريتورز اللي كانوا موجودين معانا النهارده، وعقبالكم السنه.
شكرا لحضراتكم جميعا.
شكرا دكتوره حنان. شكرا دكتوره إلهام.
شكرا.
Thank you dear professors and doctors.
Thank you. Bye bye. تصبحوا على خير.